Good morning, dear friends, seniors, mentors, and my dear colleagues. I hope in this global crisis, you and your loved ones are safe and well. With the upcoming vaccination, let's be optimistic and have a live conference and get together in the forthcoming years. Today, the topic that we are going to discuss is perfusion strategies for aortic arch surgeries with different cannulation methods, sharing our experience. This is to understand the basic idea of aortic morphology. In aortic arch pathology, we have Stanford classification type A and type B, and we are concerned with the type A where the ascending aorta and the arch of aorta is involved. To begin with, complex aortic surgeries needs a meticulous planning and team effort for a better outcome. Various perfusion strategies have been described in the past to prevent the morbidity and mortality. With the use of different cannulation for perfusion of upper and lower body, it reduces the ischemic time during hypothermic circulatory arrest. The central cannulation offers the advantage of antegrade perfusion of the aorta. In addition, performing low body perfusion at the same time will enable safe increase in the systemic temperature during CPB. The aim of our study is that we have analyzed the different arterial cannulation sites and the relative flow modification to the upper and lower body in accordance with the temperature. From January 2011 till April 2020, 128 consecutive patients underwent complex aortic surgeries such as aortic root replacement, arch replacements, redo aortic repairs, frozen elephant trunk procedures were reviewed. Depending upon the patient's clinical scenario, either of the right axillary artery, innominate artery, carotid, or femoral artery were used for arterial inflow. During open heart surgery, the total circulatory arrest of the lower body and bilateral antegrade cerebral perfusion were established. This is our routine. Median sternotomy, the cannulation sites were axillary, subclavian, innominate, carotid, femoral artery, venous being RA, SVC, IVC, or femoral. Myocardial protection is through either custodial or delnido, surface cooling and envelopment done. Organ or brain protection is through TCA, deep hypothermic circulatory arrest, antegrade selective cerebral perfusion, or external cooling. Regular CPB with custom-made antegrade selective cerebral circuit were used to ensure optimal perfusion and to minimize perfusion-related risk during the procedure. Cerebral or organ protection concept plays an important role. As the CPB is established, the patient is cooled for hypothermic circulatory arrest. The lowest core temperature differs from 25 degrees C to 22 degrees C. Systemic circulation is arrested and diseased aorta is open. Aortic root and arch are longer procedure. We'll try to do the root first and then go ahead to do the arch procedure. We'll perfuse the aortic root. While the root is being perfused, we'll perform the aortic arch procedure. Meanwhile, bilateral antegrade cerebral perfusion is established and adjusted to maintain the right radial artery pressure between 40 and 70 mmHg. Temperature of the brain perfusate maintained around 22 degrees C. Same time, the total circulatory arrest of the lower body is continued. Flow strategy of antegrade perfusion strategy is to deliver 8 to 12 ml per kg per minute flow at 24 degrees C to the upper body via right axillary artery, innominate or carotid. Lower body after TCA, after completing the arch procedure, controlled perfusion to the lower body was delivered around 1 to 3 liters flow per minute via femoral artery or the side branch through the Dacron graft on rewarming. This is a bilateral antegrade cerebral perfusion through the innominate artery and left common carotid artery. Among our 128 patients, these were the percentage of choices of arterial cannulation that were used. Femoral artery, axillary artery, and central cannulation are the most widely adopted cannulation strategies, which are more or less equally distributed. In both acute and chronic settings, the right subclavian artery were 33%, femoral 28, innominate 28%, carotid artery comprising 6%. Results that we have is like simultaneous upper and lower body circulation after distal arch anastomosis via different cannulation technique is feasible. It helps to reduce the TCA time, and deep hypothermia is avoided in these cases. The total circulatory time in all 120 patients was around 30 plus or minus 10 minutes, and the reduction of TCA time improves the overall survival of the patient. Thus, the effective preoperative planning and coordination between the surgeon and perfusionist brings out the better patient outcome. In the perioperative variables, with the use of different cannulation for perfusion of upper and lower body, the ischemic time is low, 36 minutes plus or minus 20 minutes. The SAP time is around 52 minutes with plus or minus 40 minutes. Our perioperative variables of three groups like axillary, innominate, and femoral, the valuables are more or less the same. The monitoring aspects were TE, Doppler, arterial blood gas or venous blood gas. The lactate levels were 6 plus or minus 2 during rewarming. Post bypass were considerably low, around 3 plus or minus 1.2. Post operatively, 2 patients required temporary dialysis. In hospital mortality among these patients were 4%. In aortic dissecting aneurysm repairs, especially when aortic arch is involved, inadequate blood supply to the brain may occur during CPP when the reconstruction to be done. Furthermore, under imminent risk of aortic disruption or in the presence of atheromatous plaques, the conventional arterial cannulation site is questionable. This makes necessary for the choice of an alternative technique such as femoral, axillary, or subclavian. The main agenda of presenting this retrospective analysis study is, as perfusionists will have the idea of selecting the cannula sites and cannulation sites if we have the knowledge of the cannulation strategy. Femoral artery cannulation for redo cases and unstable patients, we go for femoral artery. Axillary artery for antegrade cerebral perfusion. It can be used as SACP circuit also. Central aortic innominate cannulation. It is quick to establish and it is under direct visualization. All this cannulation has got certain amount of disadvantages, which will be better to know. Both the cannulation sites in acute and chronic, the distribution of cannulation were more or less the same according to Roberto De Paulis. In the meta-analysis of retrospective studies, the 3 major sites shows the similar outcome, whereas the p-value is lesser than the 0.05. That means the outcome, the patient outcome does not have any significance with all these 3 cannulation. The variables are almost the same. This is also the study stating the same. And some studies show that they have the better outcome in using all this cannulation strategy. Of course, we had limitation. Our study were retrospective in nature. Cohort size is small, limited variables. It's a non-randomized study. To conclude, various arterial cannulation do not have any significant relationship on the outcome of the patient. In our study, we observed that every complex aortic surgery required different cannulation strategy for adequate perfusion of upper and lower body. We conclude that there is no specific guidelines or methods for cannulation which is superior in aortic heart surgeries. Thank you.